republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Roll call, please, Sarah.
Johnson?
Here.
Lathrop?
Yep.
Mayor?
Here.
Wheelock?
Yes, ma'am.
Crawford?
Here.
Show Klaus and Gorfulet is excused.
Cheryl might join us.
She might join us, yes.
We'll see. We have approval of the minutes. We have minutes of June 6, 2018, regular meeting. June 7th, special meeting, community forum. And June 8th, special meeting. Any
Madam
changes?
Chairman, I would move to approve the minutes of June 6th, 7th, and 8th as provided.
I'll second that.
Moved by Commissioner Wheelock, supported by Commissioner Mayer. Any discussion? All those in favor say aye.
Aye.
Any opposed? Okay, thank you. Now is our chance for first public comment. Sarah, will you read the rules, please?
Any person shall be permitted to address a meeting of the Board of Commissioners which is required to be open to the public under the provision of the Michigan Open Meetings Act. Public comment shall be carried out in accordance with the following board rules and procedures. Any person wishing to address the board shall state his or her name and address. No person shall be allowed to speak more than once on the same matter, excluding time needed to answer commissioners' questions, if any. The chairperson shall control the amount of time each person shall be allowed to speak, which shall not exceed 3 minutes. The chairperson may, at his or her discretion, extend the amount of time any person is allowed to speak. Public comment will be solicited during the 2 public comment periods noted in Rule 5.4, Order of Business. However, public comment will generally be received at any time during the meeting regarding a specific topic currently under discussion by the board. Members of the public wishing to comment should raise their hand or pass a note to the clerk in order to be recognized and shall not address the board until called upon by the chairperson. Please be respectful and refrain from personal or political attacks.
Okay, with that said, do we have anyone for first public comment today? Don't be shy. Yes, sir, Sheriff?
Good evening, Tom Bensley, Grand Traverse County Sheriff. I'm unable to stay for the remainder of the meeting, so I want to make some comments about a topic you will be talking about later. I'm going to ask you to oppose the resolution allowing for a needle exchange program in Grand Traverse County. All the information that has been presented so far has supported a needle exchange program. At the Sheriff's Office, we're charged with enforcing the law. Illegal drug use in any form is against the law. Our job is to investigate, arrest, and with the prosecutor's office, prosecute illegal drug users. This program of needle exchange just flies in the face of our responsibilities. In a way, it somehow indicates we should turn a blind eye to our responsibilities. Harm reduction programs do exist. They can continue without the exchange component. I know the city of Traverse City is all in on this initiative. So I would ask you that if you support this initiative, that somehow your resolution makes it specific to contain the program or programs within the city of Traverse City and not include the county. All of the information you read, please, or hear, don't believe. And let me give you a good example. This is the 2017 Michigan traffic crash data for Grand Traverse County, and they slice and dice the information every which way. We had 8 fatal accidents. This comes from our accident reports submitted electronically to the state. 8 fatal accidents, unfortunately, last year in Grand Traverse County. This is the 2017 medical examiner's report, which covers several counties, and I'm guessing it's from Western Michigan University, the medical examiner's office. And according to this, remember, this data indicates 8 traffic fatalities. The medical examiner's office indicates there were 23 fatal crashes. That's not even close. So when you're looking at data, when you're looking at things, And you can go to the internet and get all the pros and cons. Take a side and go to the internet, and you can line them up. This is bad public policy. It legitimizes illegal drug use, and it may be paid for with tax dollars. As the sheriff's office, we cannot support this initiative. I've been called a dinosaur because I don't support the needle exchange program. Well, that's fine. But this dinosaur has his duties and responsibilities as a law enforcement officer set with and aligned with a moral and ethical compass that's pointed in the right direction. Thank you.
Thank you, Sheriff. Anybody else for first public comment? Once, twice? No? Okay. We will move on to approval of the agenda. I just have one change. I know Mr. Cooney is going to come and in discussion for our new administrator's contract. So I would just ask that we can move on with the agenda, but we go with that as soon as he comes in. Is that okay with everybody? So that's kind of a floating agenda item,
Okay with me?
because he has someplace else to be, so, is that okay? Okay. So with that one change,
I'll motion that we accept the agenda as is with that one change according to when Mr. Cooney comes.
okay?
I'll second.
Moved by Commissioner Mayer, supported by Commissioner Lathrop. Any discussion? All those in favor say aye.
Aye.
Any opposed? Okay, so we'll move on with Mr. Cooney and the contract as soon as he gets here. Let's move on with the consent calendar. Sarah, please.
The purpose of the consent calendar is to expedite business by grouping non-controversial items together to be dealt with by one commission motion without discussion. Any member of the commission, staff, or the public may ask that any item on the consent calendar be removed and placed elsewhere on the agenda for full discussion. Such requests will be automatically respected. If any item is not removed from the consent calendar, the action noted, receive and file, or approval is approved by a single commission action adopting the consent calendar. All information identified on the consent calendar can be viewed in its entirety at www.grandtraverse.org. A, receive and file. 1, Northwestern Regional Airport Commission minutes of April 24th, 2018. 2, Community Collaborative meeting of May 24th, 2018. 3, Michigan Township Association minutes of June 7th, 2018. 4, Road Commission report. 5, Treasurer's quarterly first quarter of 2018 and annual report 2017. B, approvals. 1, Commission on Aging change to staffing plan. 2, 2018 Clean Sweep Grant Administration. 3, 2018 L4029 approval of corrected form. 4, Treasurer foreclosure fund excess proceeds. 5, fiscal year 2018 budget amendments. 6, May 2018 claims approval.
Okay, does anybody have anything that they would like removed from the consent calendar and discussed elsewhere? Anybody from administration? Anybody from the public? Okay, do we have a motion?
Move that we accept the consent calendar.
Support.
Moved by Commissioner Johnson, supported by Commissioner Wheelock. Any discussion? All those in favor say aye.
Aye.
Any opposed? Okay, thank you. We will move on to MSU Annual Report, MSU Extension. Jennifer, welcome. I will not interrupt you if Mr. Cooney shows up.
Well, that was going to be my question.
No.
If you needed me to
You
float,
You have this block of time now.
I would float away and then float back should
You're
you need
fine.
me to.
You have
Okay.
this, you have the floor. Yes, go ahead.
Again, just Jennifer Berkey, Michigan State University Extension. It's my distinct pleasure tonight to be here. I think I have a particular amount of pride, as always, when I present this report, partly because this is my county of residence. It's also my home county as an employee, and so I feel particularly proud each year of the work that we've done on behalf of Grand Traverse County residents. So again, thank you for allowing me to be here this evening. This report that I'm going to present visually on the screen is just a kind of a summation, if you will, of some of what I consider to be the most significant impacts of what we've achieved over the last year. And so I'll go ahead and move through the slides and hopefully try to touch on some of our key impacts that we've achieved here in Grand Traverse County, as summarized as well in your report too. So I always like to start out just by reminding the board that we are funded by multiple funding sources, both with our county partnership. We couple that with our state dollars, federal, and grant dollars, which is now our largest segment of funding for our staff and our operations. And in this county, I always feel that our $1 invested by the county yields $6 in programs and services. I always feel that's a little low, but that's the figure that we typically use. But Grand Traverse County always typically tends to be a higher impact county, just given some impacts you'll see in the report. Last year, we reached over 9,000 county residents through all of the programs that we do on behalf of Grand Traverse County, which to me was really substantial and, in my mind, just very notable. So we'll start tonight with some of the 4-H work that we do. Karen Stevens is right now. She has led our crew of students that have gone to 4-H Exploration Days for the last few days, exploring the campus at East Lansing and learning a bit on campus about what different types of life is like on campus and some learning opportunities. So she's not able to be here tonight. But pretty much 4-H, we build youth here in the county, teaching them life skills, workplace preparation. We also help focus on some STEM learning, which is science, technology, engineering, and mathematics, as well as teaching them how to be leaders so that they could at some point replace all of the commissioners here and step into the shoes of all of you and continue to lead through your example, as well as lead in other ways throughout the community. So just here's some of our impacts that we had over the last year. So we had over 3,000 direct youth participating in a variety of ways. Karen's very creative in her outreach, and she's been doing quite a bit of work in the community doing actual hands-on learning with robotics and sciences. We also partner with some of our health and nutrition staff and teach health and nutrition to the youth, as well as outdoor education, archery, and shooting sports. So again, this is accomplished through presentations with groups as well as through traditional club activities. So Dr. Lathrop reminded me what the 4 H's were for 4-H, and one of the ones I'm most proud of on this slide is community service. So this last year, 4-H'ers really gave back to Grand Traverse County through beach cleanup activities, food pantry collections, as well as a water safety event that they partnered with local groups that had a vested interest in that, and that's one of our pictures. Also, one of our cornerstone programs is obviously our livestock auction, where youth raise animals that are sold at the auction. Sometimes they donate those proceeds back to others, a particular community project, or they raise that particular animal, sell it at livestock auction, and then they are able to invest that money in all sorts of things, maybe college education, some of their school expenses, or anything that they have needs for. So again, we had 406 local youth that participated. 19 animals were donated to local food pantries, and over 1,100 youth participated in the Livestock Council program last year, which raised $654,000 back in the pockets of the 4-H'ers to invest as they need to see fit. The nice thing about livestock and the livestock program is it teaches youth business practices. It teaches them break even. It teaches them the cost of an animal plus the care plus the feed, and what is that actual cost benefit that they would have. So really teaching them some early business skills. So I'll move to some of our health and nutrition activities over the last year, and one thing I'm really pleased to report on that came out of a board meeting here was some of our wellness activities here with the county. Sarah Eichberger has been leading a small group of county employees through a process to design healthy environments in the workplace, and so I'm pleased to report that that group has narrowed it down to about 40 different ideas after completing that assessment of things that can be done to improve the health of county employees. Then a survey was sent out via email to employees, and over 30% of employees participated in that survey talking about what we can do as a workplace to obviously improve the health of employees. This can help with the bottom line of health insurance costs and productivity for employees. So MSU Extension was really pleased and excited to partner with the county to be able to offer this to employees. We also work through a federal grant. Michelle Smith is here in the back there. She can wave. She teaches individuals, adults and youth of limited resources how to eat healthy while on a budget. So last year she reached, let me tally up my numbers here. I've got it right here. 3,117 adults and youth in both presentation and series. So again, she works with individuals, teaching them how to eat healthier and increase their physical activity so that in the converse that they'll be healthier. And the nice thing about this is they become less reliant on highly processed foods. We teach cooking classes to adults so that they can obviously cook for themselves utilizing healthier options. Another addition to the year this year was a partnership with Fuel Up to Play 60, which is a partnership with the NFL and the United Dairy Council. We received a grant to hire Caitlin Lorentz, who's actually housed in Benzie County, but she's working within a 6-county area, and she's working with local schools to help them write grants to improve their health and wellness of the schools. So over $8,600 of grant dollars were received in Grand Traverse County through this partnership. And our very own Blair Elementary was selected at a Silver Wellness Award because they met a certain standard that allowed them to get that award, so that was exciting. The funds are used to make updates to cafeterias, making menu boards more attractive, different types of equipment that the schools need to make those environments more conducive to healthy eating. So in a time when some of those schools are dealing with declining resources, this can be a supplement to them to improve the different types of opportunities for youth. So again, we're excited to have this partnership added to the community too. Patty Roth has been doing some education focusing around reducing stress and parent education to deal with alternatives to anger. And we've had two main audiences that we've dealt with in this. We've worked with schools and teachers, helping them to learn more about how to work with youth that are particularly stressed, as well as a local elementary school teaching them some alternative to anger management techniques. No presentation to the board or about our local community about not talking about agriculture. It wouldn't be complete. And so we continue to have a strong presence within our agriculture community. Obviously, with the continued pressures of spotted wing Drosophila, with our cherry industry, we continue to provide them with up-to-date information on how to combat that invasive. Our cherry community is going to have a particularly challenging year this year. Right now, it's estimated that the production of the cherries are going to be high, but due to international pressures, the cost is going to be impacted by that. It's likely that the funds that they have to extend due to spray pressures will not even allow them to have a break-even crop this year. So it's really essential to have that timely information so they're not wasting resources. So Emily Puchbay has been providing up-to-date information on how to best manage some of those invasive species during this growing season. We also continue to support our local vineyards with the hire of Thomas Todaro last year, who has been working wonderfully with our vineyard community. There's a new trial plot that's being added at the Northwest Michigan Horticulture Research Station that's supporting what growers and what winemakers want to know so that we can best maximize our crop to continue to grow this industry locally. Obviously, we continue to support our local hops with Dr. Rob Sarine, continuing to help work with this explosive crop that we continue to see acres added each year in Grand Traverse County. Master Gardener continues to be a resource that residents access as well. We have planted diagnostic clinics at the Grand Traverse County MSU Extension Office where residents can bring their disease bugs, dying plants, all sorts of things, and then Master Gardeners volunteer their time and staff that. We also have 61 active Master Gardeners in our community who are working on 17 projects. These projects have to be educational based and a benefit to the community. Like, I can't have them come and help in my garden, but they could work at a community garden where the food that's gleaned or grown in that would be donated back to the community. And last year, they donated 2,200 hours, which was a value of almost $50,000 if you factor in the cost of a volunteer hour. So again, our Master Gardeners continue to be an essential part of the work we do here in Grand Traverse. Again, every year I always feel like I have nothing but good things to say about our product center work. And again, just a reminder what that is we work with local entrepreneurs who have a food or agriculture-based idea, taking it from idea to marketplace. And we have, well, let me say Grand Traverse County has the best numbers north of Clare. When I say you truly have a mecca of ideas and entrepreneurs here that are really taking their ideas to the marketplace. MSU staff did 113 sessions, which created 16 new jobs through the innovation of that entrepreneur, plus the product center guidance through the process, which yielded an $899,000 increased investment value of those businesses. So again, it's really helping to be an economic boost in an area that truly has wonderful ideas. We have a mecca of locally grown food, and you couple those together and you've just got a great synergy for the product center. And I know you're familiar with John Amrine, who's able to be here tonight. Thanks for coming, John. He works within our government and public policy work, and you probably have been, well, I know you've been the beneficiary of his knowledge and education. He's helped to support this local board as well as other municipalities work towards facilitation of strategic planning for the joint Board of Commissioner and Parks meeting. He also helped to bring to the table, well, let me say, he helped to foster a team that brought to the table a Get Engaged local governance leadership program, which was one of a kind and was started here in Grand Traverse County and is now being replicated across the state. So again, another example of innovation occurring here, and that was under John's support and leadership as well. He also provides a great deal of other resources to the board, so I encourage you that if you have a question on good governance or a question on how to help, what are some best practice for that, you have your own resource here in Grand Traverse County. And because I always like to kind of end focusing on some of our Great Lakes, we obviously have Mark Breederland, who works with some of our freshwater ecology. We're surrounded by our beautiful bays. We also have had some ebbs and tides in the levels of the water and invasives coming in, and Mark is our go-to person for that. We always typically have questions on water levels and what's that new something that's coming into the bay, and so he's a true resource for us here to help work with marinas and other municipalities to help manage their water resources better. And I always like to just conclude by saying thank you for allowing us to give this presentation tonight, as well as the partnership between Grand Traverse County and MSU Extension to allow us to do the education and outreach for your citizens. So thank you. Yes, sir.
Yeah, I'd also like to thank John Ammerhein for facilitating the meetings of the Northern Michigan Association of Counties that take place in Grayling, and I attend those meetings.
Good. We try to bring information that's vital so that you can make good decisions, or try to look ahead and say what might be cutting edge so that you can utilize that new information as part of your meetings and decision making. So thank you.
Any other questions for Jennifer tonight? No?
Good job.
Yep.
Yes,
Tried to
excellent
keep on
job.
my time window, so thank you. There's a
Thank
lot
you.
to cover, and it's hard to choose what's the
No,
most
it's
important.
okay. I like that our investment, of each dollar brings us like $6 in services.
At least, I think it's more than that, just if you look at the product center and the additional grants and the staff that we have here. We have a very robust amount of staff that serve this area because it's our largest county center in my 6 counties, so.
It's hard to
But thank you.
quantify, but
Yes, it is.
Yep.
It is, especially like 4-H. How do you quantify what you're giving the
What they're-
kids,
yeah.
that they carry on the rest of their life, so.
Well, I do know that they're gaining additional leadership skills as we speak, so I look forward to hearing good reports from Exploration Days, and I always hope for a dry experience that's not too hot for them, so no air condition. So, okay,
Okay.
anything else for me?
Thank you.
Thank you.
Thank you very much. Okay, we are going to move on. We didn't have any items removed from the consent calendar, and we have moved up our administrator's contract approval because Mr. Cooney is now here.
I gotta pull back the email here.
Welcome.
Thank you.
Bob sent us earlier this week our administrator contract. myself and Bob Johnson and Ron Klaus met and came up with some terms, right?
Yes, and I could run through those
Yep, if you could.
terms that they decided upon, or the advice they gave me as far as preparing the contract. And essentially, the start date is still up in the air. I haven't heard back from Nate, but the committee agreed that he should talk to the sheriff and agree upon a start date. I think both the committee and Nate were hoping for July 1st, so I'm not sure what the sheriff has said about that. As far as termination and severance pay, it's 6 months if without cause. The salary was set at $124 to begin, with a $3,000 increase each of the next 2 years if the administrator meets or exceeds expectations. The employer shall review 2 months prior to the anniversary date of the administrator's hire to determine whether the administrator is performing up to standards. And let's see, with health benefits, those stay the same. Other fringe benefits stay the same. Other than the 401k contribution, Mr. Alger is on a defined contribution plan. He switched back when the county switched over in 2000, I think it was. He was given some kind of payout for that, and since then he's been on a strict 401k plan. So there is some disagreement about that. The committee wanted him to have the same defined contribution plan as new hires. About 3 years ago, we went from a plan that is 6% contribution from the county. If the employee contributes 3% of their salary, then the county kicks in another 3%. So that's 9% from the county. The new plan that was started, again, I think it was about 3 years ago, is a 3% contribution from the county, and if the employee puts in 3%, the county kicks in another 3%. So that's a 6% contribution from the county of the gross salary of the employee. So Nate would like to have the same plan that he's had since he switched over to the defined contribution plan. The committee came up with 20 paid days of vacation, and also that any personal time or floating holidays would be paid out to date and shall be available to the administrator through December 31st, 2018, in accordance with the policy applicable to all other non-contract exempt employees. That's what Mr. Alger would like added to the contract. Essentially, he would his accrued sick leave bank, which is about 256 hours, around that. That would remain there, and he would be paid out upon separation. Okay, he would be paid out at the end of this year, after December 31st, for any accrued personal leave, which is 5 days essentially. He can use up to 3 additional days that he doesn't get compensated for. It's use it or lose it. And also any floating holidays that he still has available. Those would be paid out after December 31st unless he's used those. As for, and there's something that I omitted here under professional development. The committee's recommendation was up to $2,000 for membership in a professional association such as Rotary. I didn't put the up to 2,000 in there, but I know when I discussed it with Nate, he was okay with that. Other than that, the only issues that Mr. Alger had were with the adding the part about the floating holidays and the accrual of time and how that would be paid out, and also the 401k contribution from the county.
I have a question here in section 7, the professional development. It actually says employer shall not pay. for administrators' membership in civic organizations such as Rotary and all that. But I thought we had agreed to, is that the change that you just made?
Yeah,
We had
I
agreed to
guess
up to
that's a
2,000.
problem too. So, okay.
Okay,
So, yeah, it's up to, the committee recommended up to $2,000 for membership in those associations. And Mr. Alger was fine with that.
okay.
Are we
Dan?
going to vote on this today?
I hope to.
Okay.
Yes.
Want to know, yeah.
Yes.
So
Who
can I
has-
make a comment?
Absolutely.
I do support Nate keeping his old 401K. I think that he's the lowest paid county administrator we've ever had, and Tom Menzel was a little lower for a period of time. He's really, this is a unique situation. He's not a new hire, he's just switching departments. So I like to see him keep that original 401K. Just my opinion.
Anybody else have any comments?
I would-
Go ahead, Sunny, and then Tom.
I guess the comment that I would make is, you know, I was part of that whole discussion about the 6% and then the 3% and the matching percent back in 2001. So, you know, I certainly understand his wanting to continue that same program, and I would support that.
Okay.
Because, you know, that's, you know, the way it's been, it was negotiated, it was all part of that decision to close defined benefit programs for county employees back in late 2000, early 2001. I don't know exactly when Nate signed his, but basically it was either late 2000 or early in 2001. So I certainly would support that decision. I think that's justified. And as far as the floating holidays, I guess if you didn't let him, you'd either pay them out at the end of the year, or you'd let him hold them until separation. I'm not sure what the difference is. The money is due him
It is.
one way or the other. So it's either you're going to pay it now or you're going to pay it at such a point as it, you know, he is no longer employed by Grand Traverse County. So I don't have a problem with that either.
Okay. Tom?
Well, I just want to say that I support the decisions that the contract committee has made. I had one constituent ask me if it's possible that county employees, when they switch jobs, can double dip and get retirement twice. That is not what we do. It's actually a lengthy period of time in between when they would leave a job and when they would be able to allow it to come back and start another job. So 3 years. Yeah, 3 years. Yep, that's a good, long time. Let's see, there was one other thing. Oh, well, it doesn't have anything to do with the contract, but before the contract is in effect, I just want to say that my position on jobs here with the county is that they should all be advertised and posted. So there'll be a couple important hires soon, or at least, you know, discussion of it. So the deputy administrator hire will be important. There are 30-some applications in the HR department from when Vicki Uppel was administrator. I don't know how you want to handle that, but I think they were sent a letter saying that they would be reviewed and they would be contacted once we had a new administrator. So could be 36 applications possibly. So I'm concerned about that we actually, you know, do that, especially in the, you know, the higher profile positions that we advertise and post jobs, because we're government. This isn't a private business. So I feel pretty strongly about that. And then the other job would be the HR director job. You know, we've gone a long time without an HR director, and that's going to be coming up. We'll have to do something about that.
Okay.
So basically, once we make our decision to hire Nate, Nate is, you know, in charge of hiring all the other positions in the county, in case the public doesn't realize that. And that's why I just sort of want to preempt whatever might happen in the future with my position. My personal policy position is advertising and posting jobs, so the public is aware and has a fair chance. Thank you.
Okay.
Nate should be given an opportunity.
I will. Bob, do you have anything to say?
Nada.
Nada. Nate?
Thank you, Mr. Cooney and the committee for the discussion. I appreciate it, Board. And I have talked to the sheriff, and July 1st is an acceptable date.
Good.
Good. Awesome. So we have the date, we have all the changes.
Yes. So I think if someone wants to make a motion to accept the contract as written with the additions included that were recommended or requested by Mr. Alger, and removing the word "not" after employer
Section
shall
7.
in Section 7, professional development. I'm not sure what they were trying to do. It sounds like distinguish Rotary from professional associations.
sure.
and so, yeah, as opposed to civic
Okay.
groups.
think-
Yeah.
Sarah is probably typing that motion as she goes.
I'm getting the intent, yes.
So a so moved would be okay.
So move.
Okay.
Support.
Moved by Commissioner Lathrop, supported by Commissioner Wheelock. Any further discussion?
I assume we will add the July 1 start
Yes.
date.
Yes, that's already in
And
there.
and that will all be set. I think we're good, and I'm very pleased to have this moving forward.
Okay. All those in favor say aye.
Aye.
Any opposed? There you go.
Congratulations.
Congratulations, Nate.
you.
Yay.
Thank you.
Yeah.
Okay,
Put
thank you,
some
Mr.
pictures up
Cooney.
now.
What's that?
You can put some pictures up in his office.
Yeah,
now.
feel free. We can actually get you a real nameplate made and everything.
Great, well, thank you very much.
Yes, we
Been
look
quite a
forward to it.
process, but I appreciate it.
I get to work.
He still has a couple weeks, July 1st.
Oh, that's right. Gosh,
Yeah.
we can't boss him around yet.
Not yet.
All right.
Well, the sheriff's working on that part.
Oh,
He still belongs to the sheriff for another couple weeks.
you think he was bad?
What's that?
If you don't think he was bad, we're gonna be much worse.
Probably, yes. There's 7 of us. There's
That's
only one of the
right,
sheriff.
No, no.
There's only a few of us that come in and bother people.
Yeah.
Who are you looking at? Okay.
Moving on.
Moving on. Departmental items. Community corrections. We have a 2019 annual grant application and acceptance. Oh, there she is.
There she is.
Welcome.
I was hiding.
Wow.
Good evening, Sri Shively. I'm the manager of Community Corrections. Every year I come before you because I have to submit my grant application to the State of Michigan Department of Corrections for our programming. I have submitted it in April. They allow us to submit it and then we get your permission later because they only give us 3 weeks to complete the entire grant. So it's not enough time for me to complete it and come before anybody because I have to get it also approved by Antrim and Leelanau before I come before you as our fiscal agent. So it is the same amount it has been the last 2 years, $264,256. And so I'm just asking for you to approve the submission I already submitted and receive and file when we do get the funds.
So moved.
I'll second that. Oh, Sonny beat me.
Sunny beat you.
I just think-
Moved by Commissioner Johnson, supported by Commissioner Wheelock. Go ahead,
The
Sunny.
comment that I would make is that, I have sat on the Community Corrections Board for a long number of years at this point, and the work that Sharice and her staff does with helping integrate people coming out of the jail back into the community is huge. We had a number of discussions last night at the Jail Ad Hoc Committee, specifically talking about the difficulty people have integrating back into society, if you will, and getting back into the community. Community Corrections helps us with that a lot. And, I'll be bringing you a proposal with some other things coming out of the Jail Ad Hoc Committee within the next little while to
Good.
help improve that.
Okay. Seems they do a lot with a little, definitely.
When you don't know what to do with somebody, that's who they call is our department. So
Awesome.
we're creative with what we do. We just are trying to help people. So
Anybody else? Any questions? All those in favor say aye.
Aye.
Any opposed? There you go.
thank
Nice
you.
job, Sharice.
That was easy.
I told you I'd keep it close.
More and more, I think we need an easy button. That was easy. And here comes Wendy, all set for her next spot.
Well, I am actually going to turn it over to Dr. Joyce DeYoung, the
Yep.
medical examiner, to give the end report.
Yep.
But she will be addressing the mysterious 8 accidental deaths versus 23 for the medical examiner's
I'm
office.
curious.
And why statistically you shouldn't compare an apple to an orange.
Thank you.
So, let me just
Okay. Welcome, Dr. DeYoung.
Thank you. I am Dr. Joyce Young, the medical examiner for Grand Traverse County, as well as a few others. And I know you have a full agenda tonight, so I'll keep this relatively brief, but I would like to go through a few highlights and information about this full year. This is we have a full year of data for Grand Traverse County. I became a medical examiner last January. Some of the counties that we only have partial data, but we do have 1 year. You can't do a lot of trend analysis with 1 year, but we did pull up some others. But I'll also address some of the other things. If you look at Grand Traverse County here, and when we look at when deaths that are reported to the medical examiner and deaths that are of concern to us are deaths that occur in the county. Now, a death that occurs in this county doesn't necessarily mean that the incident or the event that ultimately resulted in the death occurred in this county. And so there were 1,314 deaths that occurred here. But if you were in a traffic-related incident, for example, in Leelanau County or Antrim or anywhere else around here, and you were transported into Grand Traverse County, and this is where you were pronounced dead, that's considered a traffic-related fatality for this county. So for us, the law is where was death pronounced? And that's kind of where, some of these numbers, and I'll show you some comparisons as well with a few other counties, but that's, again, where there may have been 8 fatals that resulted where it was actually in Grand Traverse, but others that came in. Another factor to keep in mind too is that from our standpoint, if somebody was in a severe traffic, or we use traffic because that was brought up, if you were in a traffic-related collision maybe a couple years ago, and you've been hospitalized ever since, and you've had complications with that, maybe you had a closed head injury, and you're the 25-year-old who's now in a nursing home or extended care facility, and you die 2 years later. If the incident that caused that death ultimately was traffic, that too is related. The death occurred in 2017. The actual event that resulted in the death may have been a couple years earlier. So that could be, that's clearly the explanation, because I'm comfortable that we had 23 traffic-related fatalities where the death was pronounced in this county. So if you look at this, then we had about 1,300 total deaths in the county. Not every death gets reported to the medical examiner's office, which is good, or we'd be exceptionally busy. But 380 of them we actually investigated 249 of them. So some of them you get a report and you say that doesn't meet the jurisdictional criteria. But some of the other factors that go into this, so not all 249 of those even turn into autopsies. And I think some of that is reflected in some of the other work that we do, that in some cases, if let's say somebody dies at their home, they haven't seen a physician in a number of years, it appears natural, or maybe they did see a physician, but they haven't been to the doctor in a couple months or a few months, that physician is not comfortable signing the death certificate. We'll go through, and based on the scene investigation that's provided by the investigator, and we'll look through all of the medical records that we can have available and make a determination of what we believe the cause of death was. So a lot of our work doesn't, I think there's sometimes this perception that everything we do is just autopsies, but there's a significant amount of work that goes into just evaluating deaths that maybe are outside of a hospital and natural. Obviously, some of them may be in a hospital and unnatural. But we do have, we have a number of autopsies and other postmortem exams there. I think other factors that other things that are going on, we refer cases to Gift of Life with I think we did 44 referrals last year, which is pretty significant, which even after somebody is pronounced dead, they can still donate corneas, heart valves, and tissues for procurement. So it doesn't mean you have to, if somebody's a donor, it's not just that they were kidney, livers, lungs, heart for transplant, but there's also other tissues and corneas that can be procured and used. We have the other kind of probably a significant activity that does occur is cremation permit reviews. And when we before somebody can be cremated, the death has to be reported to the medical examiner, and we do not a complete investigation. We don't go out to the scene, but we're looking at the death certificates. We're looking for anything that might be an unnatural death, and so this is a county that has a very high percentage of cremations, with 76% of the deaths that occur here also cross our path and cross paths with the medical examiner's office, where we're looking at those. I want to show now, like, just by sometimes counties compare themselves, and if you look at these are the counties that where I am, some of the counties where I'm the medical examiner that have sort of populations that are somewhat near, but I also looked at like counties that have the number of deaths that occur in your county. And really, for us, although population does have some bearance on how busy we are as a medical examiner's office, what's more important is how many deaths are occurring in that county. So although you're kind of between Van Buren and Allegan with the population, if you look at ours, you're closer to Calhoun County, which obviously has a significantly higher population in the number of deaths that are occurring. Even with that, though, so if you have about 1,300 deaths occurring here and about 1,400 in Calhoun, they had a higher number of deaths that were reported to us. They actually, if you total, how many postmortem exams, autopsies were done, there were 77 for Grand Traverse, but 151 for Calhoun. And this is, part of it's just the population, different risk factors. We use the same criteria for deciding whether somebody should have an autopsy done, regardless of which county you were pronounced dead in. So we do the scene investigation, all that, and we use standard criteria established by the National Association of Medical Examiners. So they clearly have a significantly higher autopsy rate. But I think, too, part of that relates to, although they're if you look at them, going down the list here, how many deaths were accidents, how many homicides were there. But this one here is accidental drug. How many accidental drug-related fatalities there were? You're actually closer to your Van Buren and Allegan numbers compared to Calhoun, which had 44 drug-related fatalities, for a very high percentage there. Like I said, the traffic deaths doesn't mean that you had 24 traffic crashes that resulted in fatalities in the county, but because you have Munson here and people are brought into this county, and this is where they're pronounced dead, so it makes Grand Traverse significantly busier. So other things that happened, there's a severe shortage of forensic pathologists in the country. There's only about 500 of us, and because the offices are very busy, primarily related to opioid-related fatalities, especially in the bigger cities, there's a lot of people that are just getting out of forensic pathology. They don't like the workload anymore, and so, but we were able to recruit. We are fully staffed now. We recruited Dr. Ted Brown from, I don't say we stole him, but we stole him from the University of Michigan, so that was kind of sorry to the Globe Blue people, but he's very happy with us. So we are fully staffed, which also helped us as well. I implemented something shortly after he arrived that I wanted, although the national standard is that your autopsy report should be, 95% of them should be done within 60 days. I switched that to 90% done within 30 days. I was not very popular at work after doing that with my staff, but I thought, being fully staffed and having, our tox results are coming back, everything's coming back. It took a little bit of a shift, but we do have most of our autopsy reports are now getting out. In 2018, our average is about 23 days, and for all of last year, it was 39 days, which is really, it's important to, if you're just trying to handle your state, the prosecutors need this, law enforcement needs this, they need the reports in order to proceed. So that it's helpful to be fully staffed and to be able to do that. I do want to point out just something that's happening. There's a lot of focus on drug-related fatalities. If you're wondering, sometimes they talk about opioid-related fatalities, and just, I threw this in here in case somebody goes, well, what really does that include? And it means not just heroin or some of the synthetic drugs like fentanyl and these fentanyl analogs that are coming in and being shipped in from China and Mexico, but also legally prescribed drugs such as the oxycodone and codeine, hydrocodone, morphine. So it's all of those. Those are all considered opioid-related fatalities. So whether you die from a heroin overdose or you die because you took too much oxycodone, those would all be classified as opioid-related fatalities. In 2017, there were 23 drug-related deaths. 4 of them were suicides, but 19 were accidents. And of those 19 accidental drug overdoses, 17 of them had opioids, and 13 of those 17 had a fentanyl in it. So, and this is actually a county where we see a really high number of fentanyl, and we call these fentanyl analogs too. In fact, Grand Traverse was the first county that we identified that had this drug carfentanil, which is, was in the news as being like an elephant tranquilizer. And of all the counties that we work with, we saw our first carfentanil death here in Grand Traverse. By comparison to 2016, the numbers are up a little bit. I was able to pull some of the 2016 data, and so they are up a little bit. You'll see here that they're called accident or indeterminate. We did have 1 or 2 deaths where you just don't have enough information to decide if it's a suicide or an accident, so we sort of lump those together. But there we had 11 opioids. So we've gone from 11 to 17 opioid-related fatalities in Grand Traverse County. I want to point out, too, one of the other things that we do, and we're kind of a full-service operation that I think is important, is that we have forensic anthropologists in there, too. Like, I have these two amazing people, Dr. Jared Cornelson and Carolyn Isaac, who the Michigan law on identification of bodies is actually pretty strict. And if you are not visually identifiable, if you have a lot of facial trauma, maybe from trauma or maybe from decomposition, we're required to do a scientific ID. So even though the family says, look, that, I recognize their body, that's their clothes, they're dead in their home, we have to do a scientific ID. And I think having, for example, our forensic anthropologists working with Gift of Life. We had one case from Grand Traverse this past year, late in 2017, where the family wanted to donate the heart for valves and tissue, but it was somebody who had a shotgun wound and they were not visually identifiable. And having Anthro in-house allowed this person to be transported there, rapidly identified, and then moved to Ann Arbor where they do the procurements. And it's one of those things that we do. We really do this for the families because they want to, if something good can come of these terrible tragedies and these unexpected deaths, it makes it a little bit better, maybe eases the pain a little bit. And so that's one of these things that I just kind of like, hats off to these people. Law enforcement really likes them too, because if you're in law enforcement, I'm sure you've had like people find a bone and is this human? And we have our anthropologists where law enforcement now, they just snap a picture of it and they text message them with the photos, and 95% of the time they can look at it and go, it's animal, or gee, that looks human, and we better wait for us to get up there. So I think that's all I have for right now. So if there's any...
Oh, Doctor.
Hi, yes.
We have another item on the agenda tonight about a needle exchange. Do you have an opinion you'd like to share about that?
Do I have an opinion on that? I guess we see a lot of intravenous drug use. A lot of of the deaths that are occurring, there is a significant percentage of drug use that is intravenous. That's at high fentanyl and high fentanyl numbers. So I think if there's an interest in risk reduction, there would be benefit. I mean, I could see the other viewpoints as well, but I think we see, if you can reduce the risk of additional fatalities from these infectious diseases, there may be benefit. What I'll say, I mean, I don't want to, I don't know if my opinion really matters, except to say that we do have a significant number of IV drug abusers that come from Grand Traverse through.
Anybody else have any questions for Dr. DeYoung while she's with us?
Thank you.
We're good?
All right, thank you.
Thank you very much. Very informative. Okay, Wendy, do you have any additional comments before we move on to the next thing?
No, not on the medical exam.
All good? Okay.
All good.
We had a meeting last night of the ad hoc committee for the regional, what is it called? Regional Forensic Pathology Ad Hoc Committee. And it was Dr. DeYoung's opinion that we do need a
My
regional.
committee's a lot easier to say jail ad hoc.
Jail ad
You know,
hoc,
can-
yeah, I
can
tried
handle that one
morgue
better.
ad hoc, and Cheryl didn't like that, so we go with the official title. And Dr. DeYoung's opinion was that we do need a regional pathology center. I'll help. Yeah, and she'll help us, she's all for it, so.
Well, I think her report showed that, typically people just think of the autopsies and the number's low, but then all the other work that goes into identifying everything else is pretty extreme, so.
There's so much more to a medical examiner's office than the autopsies, and so
You know
when-
what's
so when-
Quincy? I mean, he did a
I know,
lot.
So when people just focus on those numbers, it's like, oh my gosh, that's just like, you're kind of sieving out, and that's just
Yep.
the ones that have to go for autopsy, so.
So the ad hoc committee is looking into getting the sort of the buy-in from some of the other counties, the tip of the mitt and the edge of the UP, to see what the interest there would be, and kind of moving forward with that. So, and Dr. DeYoung's offered to help us with all that, so thank you very much. So we will move on. Mitchell and McCormick, DBA Harris Public Health Solutions.
That's a mouthful.
It
It's
is, go.
basically our electronic health record at the health department. We've had it for about 5 years, and this is our annual renewal. and maintenance and support agreement, so just looking for approval. I'm happy to answer any questions. I tried to provide you with ample information in the agenda item, but we do use it a lot, and we also use it for billing, private insurance, Medicaid, things like that, so it's very beneficial for us.
And you're very happy with the service, with the
Yes.
application? Okay.
Motion to approve the renewal.
Support.
Moved by Commissioner Wheelock, supported by Commissioner Johnson. Any further questions or comments? Okay. All those in favor say aye.
Aye.
Any opposed? That was easy. Moving on. Quality improvement policy.
Okay, so this item is a follow-up to, I was here the last meeting talking about our accreditation. There's an optional component that involves a quality improvement assessment. We do a lot of quality improvement and assurance activities at the health department anyway, so we thought we may as well go for this additional sort of commendation to recognize all the staff for all their hard work. So this is just what our official policy is, and we actually have a multi-divisional team of all different kinds of staff involved, and so this is just what our policy is, and the requirement for the accreditation process is that you review and approve the policy.
Are there any changes to the policy from before? Have we approved
We
it
have
before?
not brought the policy to you prior, so
Haven't.
this is new.
Got it. Okay. All right. Dan?
Are you aware of any other departments that has a quality improvement, are you the only one, as far as you know?
I don't know the answer. I would assume other departments do various levels of
Measure and
audits,
manage?
measure, manner. I mean, we do a lot because of our grant funding and
Sure.
just the nature of
Yeah.
the work that we do and the state statutes, and the accreditation process is every 3 years, so
think that's
this
really
is really
important,
kind of a
yeah.
hallmark of things for us.
Because not only can you say you're doing a good job, you can prove it.
Exactly.
Yeah. Good.
Madam
Okay.
Chair, I move that we approve the Grand Traverse County Health Department Quality Improvement Policy as presented.
Do I have support?
Sure.
Moved by Commissioner Johnson, supported by Commissioner Mayer. Any further discussion? All those in favor say aye.
Aye.
Any opposed? There you go.
All right.
Move on toward additional greatness.
Thank you. Trying every
Okay.
day.
Harm
So, yeah,
reduction resolution.
Our next item, I'm going to have Dr. Michael Collins, our medical director for the health department. He is here to give a short presentation, and then we have some additional people from the community who might want to give some comments as well.
Okay.
Good evening. I'm Mike Collins. I'm Wendy's medical director for the health department. You know very well about the national opioid crisis, and you've just heard some statistics about the county's participation in it, the 19 deaths from overdoses. What is probably less well understood is the fact that this crisis of drug addiction inevitably brings about and includes an associated crisis involving infectious disease. This happens because and when individuals, as so often happens, move from taking oral opioids like OxyContin into intravenous injection drug use. They switch to heroin because it's cheaper and it's easier to access. That wouldn't necessarily cause transmission of infectious disease if it was done in a medical sort of manner with clean equipment. But far too often there's multiple reuse and sharing of equipment, and therefore there can be transmission of diseases, particularly HIV, and especially hepatitis C. Now I'm sure you know a lot about HIV, probably considerably less about hepatitis C, which actually is several times more likely to be transmitted by injection drug use than HIV is. So hepatitis C, as the name implies, is an infection of the liver. It's a viral infection, and it's an extremely serious one. It's almost always transmitted by drug use, like we're talking about. It's especially serious because almost everyone who contacts this particular infection keeps it forever as a chronic illness. So it chews away at their liver for the rest of their lives, eventually leading to liver failure or liver cancer. And during the whole rest of their lives, they are potentially a source of infection for others in case there would be sharing of drug paraphernalia, for instance. So when we look at hepatitis C by year of birth, as this graph shows it, we see it primarily in two groups of individuals. The left-hand peak there is baby boomers, which I guess comes from our hippie years when we did bad things and nobody knew anything about hepatitis C. But particularly of interest is that right-hand peak, where we now see it in young adults, and almost always that's related to the use of injection drugs. So this is chronic hepatitis C in young adults since 2000, and you can see it's rapidly increasing. And our county has not been exempt from that. We've, in the last 3 years, we've identified about 200 cases of hepatitis C, including, I think, 17 that were new, acute, brand new infections. So clearly this is happening in our county. So syringe service programs, SSPs, which go by many other eponyms and names, needle exchange programs, syringe access programs, and so on. This is one proven approach to the problem, and actually to both facets of the problem. It's an approach to the infectious disease transmission directly, but also indirectly, I think, an approach to the control of the underlying drug addiction problem. What it is basically is a program to which individuals can bring used needles and syringes and replace them with brand new sterile ones. So combine both helping to avoid pollution and debris in the community by returning the used equipment, as well as giving them equipment that's not going to transmit diseases and that's not been used by somebody else. As of 2015, which was the most recent year that I could get information, there were 228 such programs in 35 states in the country, 4 of which were in Michigan. I'm sure there are many more by this time. 3 years is a fairly long period of time, and these programs are becoming more and more popular. It does, as I say, combat both aspects of the problem. The infectious disease issues are covered by the services that are listed there on the left-hand column. Of course, the exchange of paraphernalia, and also testing for the illnesses like HIV and hepatitis C that might be transmitted that way, and referral for treatment of the infections if they exist, and vaccination for similar illnesses. But also the services that are listed on the right-hand side are important also in terms of referring folks for mental health services, for substance use treatment, education about overdose prevention and treatment, and other infection prevention tools like condom distribution and medication to prevent HIV. The thing is, drug users are, through a program like this, brought into contact with understanding folks who are safe for them to communicate with and who will give them good advice. And as I say, not only minimize the possibility of transmission of infectious disease, but also indirectly help with the underlying problem of the drug overuse itself. When the programs are looked at, and there are a number of cities who have looked at the statistics before and after these programs began, it's clear that they work as they would be expected to decrease the incidence of HIV and hepatitis C in injecting drug users. Furthermore, there's an increase in associated things like employment or entrance into medical health programs or substance abuse programs. They're more the folks who attend the programs are more likely to stop injecting drug use and to remain in treatment. Clearly, these programs do not promote drug use. We don't have people saying, free stuff, I should start a drug habit. It just doesn't happen. There are associated benefits to the community, and law enforcement is particularly in the cities where where these programs are in operation. Law enforcement has particularly noticed a decrease in break-ins and burglaries because the addiction problem itself is attended to, and reduced needle stick injuries to law enforcement personnel and first responders and firefighters is important as well. So generally speaking, law enforcement in the cities where these programs exist are very much in favor of them, and very supportive of them. The programs are also cost effective, considering how much it costs to treat even one case of HIV or hepatitis C. So the harm reduction Michigan people are available and able and willing to begin a program whenever they're authorized to do so. In order to do so legally, they need to be authorized by a governmental agency. Our health department is strongly supportive of the initiation of a program like this, and we would be happy and enthusiastic to be the authorizing agency and monitoring, take the monitoring role as well. So I urge you to vote in favor of this resolution. Thank you.
Anybody have any questions for Dr. Collins? Welcome, Cheryl.
I also wanted to point out that Bob Cooney, I think he probably sent it, but he wanted to make sure either Chris or I pointed it out, that they did pass a resolution in support of the Grand Traverse County Drug-Free Coalition. In support of this resolution, I do need to note that law enforcement members were supportive of the overall goals, but they abstained from voting because of some of the reasons that the sheriff brought up, which is understandable. They didn't want it to be a conflict of interest. We do have a few other people here tonight that might want to speak, if that's okay.
Okay, sure. You'll get the 3-minute public comment time, if that's okay.
Yep.
So if you could step up and let us know your name and address. Okay.
I apologize, I have a few more things. This is information from the Center for Disease Control about syringe services programs.
Can you tell us who you are?
Hi, I'm sorry, yes.
That's okay.
My name is Pam Lynch,
Okay.
and I live at 867 East 8th Street in Traverse City.
Thank you.
And probably the biggest point of interest is on the back, is some of the research that supports this programming. This intervention has been looked at inside and out, backwards, forwards, up and down, and in many areas of the country is no longer considered controversial because the science is absolutely in favor that needle services programs reduce HIV infection, hepatitis C infection, and are a conduit to drug treatment for a lot of people. And you know, since most of the country is now experiencing this opioid epidemic, there are a lot of communities implementing syringe services programs that had not previously considered it. And this is my PowerPoint, so I'll just take a minute here. Just to keep me on track. You know what? Do we have a...
Sarah's there for technical support.
So I am a clinical therapist here in town, licensed master social worker. I teach for Grand Valley University, master's level, and I'm a certified advanced alcohol and drug addiction counselor. I refer a lot of people to treatment on a weekly basis. So as you're all very familiar with the fact that we have an increasing heroin problem in our country, not only amongst youth, but nationwide. Thank you. So some of the facts are, injection drug use is increasing, and this is among non-traditional drugs such as prescription drugs. And people that have started by prescription drugs will ultimately, not always, but often turn to injection for the same reasons why we administer IV antibiotics in the hospital. It's a very efficient route of administering medication. Traditionally, what happens for people when they're opiate dependent is their tolerance will increase. And as their tolerance builds, it costs more money for people to function. And so as the cost of those drugs that they need to function on a daily basis increases, people will sometimes turn to injection because they don't have to spend as much money if they're injecting their drugs as opposed to swallowing them or snorting them. And so it's often an economic decision. So we also have new prescribing laws that temporarily may cause people to turn to heroin due to a lack of access to prescription opioid and pain medications. So there are unintended consequences to some of the laws that we've changed. Stimulants also are injectable, such as methamphetamine and cocaine. I, myself, as a therapist here in town, have seen an increase on my caseload, people who were in trouble with opiates and who have switched addictions over to methamphetamine. They're less easy to detect. We don't test for them as thoroughly as we do for opiates, and they increase the dopamine in the brain just like the opiates do. And so we really have a pretty significant meth problem now. So we've had infectious disease outbreaks associated with injection drug use all over the country at this point, associated with this opiate epidemic. So probably the most famous of which is a rural county in southern Indiana. But first, just this slide, we have more people dying now from hepatitis C virus than any other infectious disease in this country. So as you can see, in about the beginning of this opioid epidemic, about 2006, or by the time we realized what was going on and began to address it, the lines for people dying from hepatitis C and HIV, the line for people dying from HIV was coming down because we had really efficient medications and helpful medications that were implemented about 1996, and the line from hep C was going up, and they crossed in about 2006. We know more people die from hepatitis C virus than 60 other infectious diseases combined now in our country. Injection drug use networks, so networks of people who are using drugs together, are driving hepatitis C outbreaks throughout the country. And you can see Indiana circled there on that map, and that's for a reason. Probably the most famous of which was a case in Scott County, Indiana, which is a rural county in southeastern Indiana that bumps up against Ohio and Kentucky. And that very small rural county, in a 6-month period between November of 2015 and April of 2016, they found 180 new cases of HIV that were all attributed to a network of people who were sharing opiate prescriptions and sharing needles because they did not have access to sterile injection equipment. At which point, Governor Mike Pence implemented an emergency syringe access program in Scott County, Indiana, which was then credited with turning around that epidemic. 180 new cases of HIV in a 6-month period is really unusual for a small rural county like Scott County, Indiana. So when that happened, the Center for Disease Control evaluated rural counties across the country, and they identified 220 counties across the country that had very similar conditions to Scott County, Indiana, where we could potentially have the same type of infectious disease outbreak as Scott County had experienced. And 11 of those counties that they identified are in northern Lower Michigan. Grand Traverse is not one of them. I'm a therapist for Northern Lakes Community Mental Health. Some of the counties that are within our catchment area are some of these counties. We also know that people now, Kalkaska is on that map. A lot of times TNT does a good job in Traverse City. So a lot of times people who are dealing heroin will move out to where the I-75 corridor is. And so that's kind of what's happened with some of the drug trade, right? They move out to other areas where they don't have as much surveillance as we might have here in Grand Traverse County. So, so the need for syringe services programs with these outbreaks of HIV and hepatitis C have occurred in other places around the country. And so syringe access and implementing that program was credited as a major tool in stopping this outbreak. So these are the acute hepatitis C rates for 2016, county by county. And what's interesting to me, so I already mentioned that my job, my full-time job is at Northern Lakes Community Mental Health, but I also co-direct a not-for-profit called Harm Reduction Michigan. And we do hepatitis. We've recently received funding to do hepatitis C testing, and we do it all over the state. But what became really stark to me was we were doing testing. Primarily, the people that we test are people in drug treatment. So they have some history of addiction, and many of them have a history of injection drug use. And so you can see the rates in Grand Traverse County here, and if you compare them to other urban centers around the state, we actually have a higher rate of acute hepatitis C infection here in Grand Traverse County. And where it really hit home to me is we do drug testing at a big residential treatment center in Detroit, like right in the hood on 96 and Grand Boulevard. So in the month of May, which was our first official month of testing data, we tested 11 people in Grand Traverse County. 50% of those were antibody positive for hepatitis C virus. We tested 34 people in Detroit. 10% of those were antibody positive for hepatitis C. So it really woke me up and opened my eyes. This is an epidemic that's very closely related to our opioid epidemic in this country, right? The opioid epidemic in this country has been largely educated, white, suburban, young people. And that's not been exclusively who it's been, but that's a large part of who we've seen certainly dying in our county. And that was certainly reflected in the testing data for Harm Reduction Michigan at this point. So, and you can see it reflected in the state rates for 2016 as well. So, and then these are the different categories that people checked for risks they had that were the acute hepatitis C cases in Michigan for 2016. So we know that about 57% of these cases had a history of injection drug use. That's one of the risk factors they checked. But the other thing is that this is a really strong, hardy disease. So it lives on inanimate surfaces. It lives outside of the body for a significant period of time on inanimate objects. It can live in the chamber of a syringe for 64 days. So when people are sharing syringes, it may have been a significant period of time that they don't think this syringe has been used, or they may think it's been cleaned by bleach, but in fact it's still infectious. But we notice on this list of risk factors for the state of Michigan for 2016, so 57% were infected possibly through injection drug use. But we have another 40% that were possibly infected in other ways. 36% of these infections identified a risk factor as receiving a tattoo or a piercing. Because hepatitis C virus was really not identified until about 1990 in this country, we didn't control the blood supply up until that point in time, which is why you see the ads about every baby boomer needs to be tested for this disease. And a lot of people say, well, I'm a baby boomer, but I've never injected drugs and I've never used drugs, never been to jail, so why do I need to get a test? Because we didn't control the blood supply well. We also, it took us a while to get really on top of infection control in clinical settings, in dental settings, and things like this. So you can see there's quite a variety of people who were infected, but yet who didn't have a history of injection drug use. So this is really behind the need for syringe access programming in Grand Traverse County, not just Traverse City. So sterile syringes and needles should be used for all injections into the human body, not just medical. And the other problem is we see more and more discarded syringes around our communities. I have a number of patients who live up and down Barlow, and I have a young mother who tells me, Pam, I can't walk up and down Barlow without finding discarded syringes these days. And the possibility of those discarded syringes having hepatitis C virus in them is pretty significant. So that's a big concern. Addiction is a chronic treatable illness, and given the right conditions, support, and treatment, it can be changed. People's futures, people's hope can have really good outcomes. So we want to do the best that we can. You know, a good sterile syringe program, it's really not about the syringe. It's about creating a trusting relationship so that a person doesn't feel judged, so that a person comes back. A lot of people who are injecting drugs are very ashamed, and they don't engage typically with the healthcare system. And so a sterile syringe services program is one that creates a trusting relationship with those folks. And so then a person starts coming back, and a person feels respected, and they feel like they're treated with dignity. And then they start to make different decisions. They go, you know, I'm kind of tired of this at this point. Can you guys help me get into treatment somehow? So those are the kinds of things that are happening in syringe service programs across this country. Thank you for your time tonight.
Thank you. Do we have anybody else? Michelle? That's fine. Sarah will help.
Yeah.
Thank you, Sarah. Or we can just leave it like that. Oh, there it is. That's what she needed. Okay. Okay, Michelle.
Good evening. My name is Michelle Howard. I live at 435 West 11th Street. I am a Traverse City resident and a Traverse City City Commissioner. And I'm here tonight to speak to you as a fellow municipal leader because I know what a privilege it is to serve our citizens and also the pressure that we feel to do the right things. And what I'm asking you tonight is to think about also our moral duty to act in times of epidemic as leaders of our community. As I found out about this epidemic, I started to read and read and read. I'm a librarian, and I came across 10 recommendations. I only want to mention 3 to you tonight of things that we can do as municipal leaders to make a difference. The first thing is to appoint a point person within your body or within the county that would act as a person that could be a liaison with police, local nonprofits, and the city as we try to tackle this issue together. We work on many issues together as city and county, and I think this could be another one. The second thing that most studies show that can make a difference is education. In the city, we allotted $10,000 towards an educational campaign to put materials in various locations across the city, but that is just in the city. And so we're working with our nonprofit partners to come up with something that can be put in utility bills so that we can educate people to what is involved in this epidemic and how we can make a difference and how we can recognize the signs of addiction and how we can get help. So I would encourage you to join forces with us however possible. Maybe a point person could talk to me and we could do something together. The third thing that is recommended for local units of government is to implement local programs that can make a difference. Safe syringe programs, as you've already heard from so many medical professionals, who know more than I do make a difference in our communities. And as a leader, there's many things I like about the program and why I put it forward with the city. And just so you know, it did pass with a 6-0 vote to support it. It's free. It costs you nothing. That never comes with, everything comes with a price tag when you're in government. So it's free. It is legal by Michigan statute that you can do this. In the city, it was supported by our chief of police, and it is supported by many other law enforcement agencies. And finally, it can be revoked. You're passing a resolution tonight, but if you find over time that there are complaints, then you could revoke it. But what I'm asking is that you could at least just give them a chance to do it. So in summary, I'm urging you to act on this epidemic, because one thing we do know is if we do nothing, it will not stop. We have to act, we have to make a difference. And while I'm part of the committee that's doing what we can in the city, you all have a much larger scope than I do, so
I feel like you could do so much more good for people than I have the opportunity to do. So finally, I would also mention that it is not just a city problem. This is an issue that is throughout our whole county, and that's why I think we need to work together. Thank you.
Thank you, Michelle. Do I have anybody else? Come on up.
Hi there, good evening. My name is Maya Doe Simpkins. My address is 1080 Blaswick Road. I swear I'm not checking Facebook. I just have a couple notes on my phone here, so give me a break. So I am, alongside with Pam, a co-director of Harm Reduction Michigan, and I just wanted to talk about some of my experiences in other communities. I grew up in Leelanau County. I have been personally affected by substance use. About a year and a half ago, I lost a classmate that I went to Glen Lake with to an opioid overdose. Sorry. I also have lived and worked all over the country and the world in expanding and implementing syringe access programs. I ran a program in Boston that was the largest syringe access program in the Northeast. I help a program in Chicago that is one of the biggest syringe access programs in the country. I also provide support and technical assistance to rural and tribal harm reduction programs that expand access to syringe services. So I say that to you just to say that as a community begins to consider expanding syringe access services, there are generally a couple things that come up, all of which are pretty manageable, but pretty consistent thoughts or concerns. One of which is certainly this question of, if drug use is illegal, how can we do this legally? And the answer to that is actually pretty black and white. The way that we can do that legally is that Michigan law allows for, our law and our law enforcement and our prosecutors' priority are to protect our safety, our community well-being. And when syringes are provided to protect well-being and health, this is absolutely in line with and written into Michigan law. So that's how we do this legally. And I understand that there's a lot of feelings of sort of concern and gray area about this, but given that my work in Boston, I worked very closely with the Boston Police Department, and ultimately the Boston Police Department was really, really supportive of our syringe services program, and this needle stick injury thing is a real big thing around which the the support for these programs revolves. And the reason why it has such a big impact is that if I am a drug user and I am concerned that I'm not going to be able to find another syringe and that I'm going to get in trouble for having a syringe, I'm going to keep that syringe for as long as I can, and I'm going to do everything I can do to hide it. However, if I come up against a situation where I think I might get in trouble for possessing it, I'm going to discard it. So when we have syringe access programs, all of those concerns are minimized. And so this really is a protective move, not just for people who use drugs and inject drugs, but for our entire community who may come across discarded syringes. So I also want to make a commitment to you that as a person who has ran programs, I'll just finish my sentence
your
here.
thought.
Okay, sorry, I'm a little nervous.
That's okay.
As a person who's ran programs in other places, it is very common that syringe service programs actively go out into our communities and remove not just the folks who come to us of their own volition, but we go and collect syringes. And I just want to say, as a co-director of Harm Reduction Michigan, in addition to committing to do this without any cost to you, we are committing to pick up syringes in our community and take advice for where those syringes might be, and that's something that we would like to commit to. So thank you.
Thank you. Do I have anybody else on this particular topic? Okay.
Hi, my name's Dave Martin, and my address is 13937 Morgan Hill Road. I came tonight to speak in favor of this as well, and I'll keep this short. I retired from medical practice about 3 years ago. For 42 years, I was an infectious disease specialist at Munson Medical Center. When I first came on staff at Munson in 1972, we never had intravenous drug users as patients in the hospital. We had our first case that I ever saw in about 1973, and it was so unusual that we had to have a whole conference of the entire medical staff because nobody knew what to do with an IV drug user. Now, we've gone from when I was the only infectious disease specialist here, we now have 4 full-time infectious disease specialists at Munson. One of them is dedicated solely to taking care of the hepatitis C patients because we have so many. We have approximately between 150 and 200 active HIV cases in the area right now and several hundred hepatitis C cases. They've mentioned HIV and hepatitis C, and no question these are very serious life-threatening problems. But there are a number of other infections that intravenous drug use also causes because bacteria get injected through these syringes as well. People end up with bloodstream infections, infections of heart valves, meningitis, bone infections, pneumonia. I can go on and on. But it is a really serious problem. So we can think about these people who are victims of drug addiction. We can think about the problems that they face and how we can possibly help them and perhaps save their lives. And that's really important. But think about prevention primarily, and think about not only saving lives, which to me was always the most important thing, but think about how much money we could save for our taxpayers. It costs over $500,000 to treat HIV today, and we can treat them pretty well, but boy, is it expensive. And hepatitis C is also extremely expensive. If we can prevent some of these cases up front, we'd be doing all the taxpayers a great service as well. So I speak strongly in favor of it. It's a good program. It's working throughout the country. It can work here as well. Thank you.
Thank you, Doctor. Anybody else?
Hello.
You
My
can
name
lift
is
the
Nic-
microphone up so we can hear you.
My name is Nicole Precourt. I live at 108 East Front Street in Fife Lake. I stand before you all today in hopes that you will consider allowing the syringe access program in our county. I am a first responder who has seen and dealt with the impacts that this epidemic has had firsthand in our community and surrounding counties. And I say that because I also respond to other counties as well. Statistics show that this is going to get worse before it gets better, and it's important to point out a few things. I myself am not a user. I am, however, allergic to opiates. Yet I choose to help my community. I am one of the people who comes to save a life. While doing so, I subject myself to accidental exposure, as well as others do from my department. There is a great importance to let this stigma go when many others of the United States and the world have chose to add a syringe access program to help the battle with the epidemic head on. The bottom line is this: stigma can be strong, but the impacts of disease such as hepatitis, AIDS, and HIV and various infections can be prevented if the correct steps are taken. At a state level and at a governmental level, this is well known. High-risk areas have been targeted, and syringe access works. It's part of the prevention tool that also needs to be utilized to have an effective outcome. I highly encourage you guys to vote yes for this. I leave you with one final visualization. Understand there are needles everywhere: parks, bathrooms, paths, and walkways, at gas stations, alongside of the roads, and even in restaurant ashtrays. When I personally show up on a scene of a person who is overdosing, we, meaning me and my crew of people who go to try and help, may not always have the time to do a full sweep of the potential places a used needle may be. Trying to save a life is our main focus for the amount of time they have been down. In the event I got stuck with a used needle, I would like to think we as a community did everything to try and help prevent disease, not promote it by doing nothing. Thank you for your time.
Thank you. Matt?
Matt Scheck, 9th Street, Traverse City. First of all, I want to start out by saying I really recommend you listen to your sheriff. He had the right idea. Drop the needle exchange program. And I say that because this last fall I had the opportunity, I happened to be in Grand Rapids, and I caught a seminar down there. Main speaker was a medical doctor from the state of Massachusetts, Dr. Punjama Murtula Kishore. who had 52 clinics treating the opioid crisis in the state of Massachusetts. The interesting thing is that, talking about needle exchanges, he didn't use needles. He didn't have a substitute drug. He had a clinic that 52 of them with 52 doctors working underneath him that it relied heavily on family and personal relationship and lots of drug tests. People that are addicted, like anything else in society, if you're addicted to something, you will do anything to get your high, whether it's illegal drugs, alcohol, you name it. And I just thought it was rather interesting that what we're talking about here that's highlighted is ancillary diseases from using dirty needles. But in the case of Dr. Kishore, he didn't rely on needles at all. So why are we substituting needles and we're not treating the original crisis? It's putting things off. So I can just close by saying listen to your sheriff, because I think your law enforcement people out there have a better grasp of the reality of the situation. If you're going to treat it, what I would suggest for this commission to do is maybe do a further study on it. Approve what you have to approve, but the needle exchange program, I would strongly recommend that you get further help on this end to understand it. Possibly Dr. Kishore could come up here and do a seminar for Grand Traverse County. Thank you.
Thank you, Matt. Anybody else? Okay.
We will bring it back to the board.
Is there already a motion?
There is not a motion yet.
So moved.
Okay?
I'll second.
Okay. Moved by Commissioner Gorfulet, supported by Commissioner Mayer, to approve the resolution supporting the harm reduction resolution. Is that correct?
Correct.
Sonny?
Well, I understand the sheriff's concern about the fact that this possibly appears to promote illegal activity. I happen to have a niece that has done work with HIV people in Africa and other foreign countries. She's run needle exchange programs in Chicago, New York, and she currently runs 2 in Portland, Oregon. She has testified before the U.S. Senate to talk about naloxone and the drug abuse situations throughout the country and the opiate overdoses. And I struggle a little bit with the fact that if this is in fact, promoting illegal activity, but what I do know that it does is promote saving lives. So, I will support this resolution.
Bob?
Yeah, I don't support this resolution. I have direct care. Actually, I got 3 kids I adopted from my family, from a niece that's a drug addict. And the last thing I would want to do is give her more access to needles. I know it's going to sound cold, and maybe because I'm jaded, because we've had such an issue with these kids, because 2 of the 3 she took drugs with during the pregnancy. But I'm less concerned about her getting hepatitis and HIV than getting her the help she needs. And every time she gets in prison, you would think she would be ready to get the help, but she hasn't. So to me, this enables. I mean, why not build a beer tent for alcoholics and then provide them a drive home? To me, it just goes in the same thing. So I don't support this whatsoever. So.
Tom?
Well, I trust in our own health department, because that's what we're here for. We're to take advice from our staff, and I believe they're recommending this. I also know Dr. Martin very well. I know Pam Lynch very well. I know Michelle Howard very well. And I think what we really also need to talk about before we come up with our final word on this is how we're going to work with the city, because the city police have agreed and given a recommendation to the city commission that they agree. Then they had the 6-0 vote to support it. So I think we have to listen to what the sheriff has to say, because he's also a department that we take advice from. So we're getting, the thumbs up advice from the health department, and we're getting the thumbs down advice from the sheriff's department, and the city police are supportive of the idea. So it's not like everybody's in agreement, but that's what I'd like to see, is that everybody was in agreement. I seconded it because I believe we're getting the we're getting good advice from the people that we have working for us. The difference would be that the sheriff doesn't agree, and I'd like to, you know, think that maybe we could get the sheriff to agree on a different day, not today. You know, just through talking it through, you know, getting a consensus, you know, where everybody decides that they do agree, rather than that it's, you know, divisive at all. I mean, I've known Pam Lynch for probably, I don't know, 30 years. And I know that she's dedicated to what she does. I've known Dr. Martin for at least 20 years, maybe longer. And Dr. Martin is the authority, even though he's retired. In my opinion, he's the authority on infectious disease in this part of the state. And I'm sure that he has the credentials to back that up. I'm not a doctor, so sometimes when we decide things and we're not doctors, we rely on doctors for advice. And I think Dr. Martin is an excellent person to ask for advice from. And he's here today. He spoke. Pam's not a doctor, but she's dedicated to her program, and she understands it. You know, I trust that we are getting good advice and that they've taken the time to come here to help us and educate us. We don't have to be experts on every subject, but I think we're getting good advice tonight, and I think we still need to carry it a little bit further so that, you know, we're in agreement through law enforcement and the prosecutors that we're not going to, you know, we're not going to enforce something in one part of the county and not in another part of the county. That would be confusing, wouldn't it?
Mm-hmm.
Especially when people drive through the county to get from their homes to work and things like that. So
Okay,
I think we have a
Cheryl?
problem there that we need to resolve so that we can have it, you know, exist in the whole county equally and not just in the city. But if, to get started, the program is only in the city as far as like a place where somebody could enter a building and make some kind of a needle exchange. Maybe that's what it's going to have to be, because I don't want people to be arrested for something that's actually benefiting the health of the people who live here in the county. I don't want kids walking to school down Barlow and picking up needles. I don't want to find them at the beach. You know, I don't want people to be tossing them for the example that they gave, that, you know, they're trying to get rid of them. I don't want to step on one, you know. Like, I think it's a health problem. We need to deal with it as a health problem. And it sounds like the hepatitis C is the biggest problem of all. And it doesn't have anything to do with legal drugs, really. It has to do with dirty needles and people spreading hepatitis C. So,
Cheryl and then Dan.
Well, I think that it is, as Michelle stated, it's an emotional issue for some people. I respect where Bob's coming from. Totally respect where he's coming from. But I think the science is clear, and I think it's a rational decision. And I think that we're here to make rational decisions, not emotional decisions. And I'm going to keep beating that drum, because I do think that we are here to make rational decisions, not emotional decisions. And I think that the science is clear. I think we need to support this. You know, A doesn't follow B. You don't provide a needle exchange and people suddenly decide that they want to start using drugs. It's just like making condoms available. People who aren't going to engage in sex are not going to engage in sex because they can get a free condom. A does not follow B. I think that it's unfortunate that we live in a community where we have to have a needle exchange. I wish I could go back 50 years to, you know, when we didn't have to think about these things, but we're not going to solve the problem by pretending that it doesn't exist, because it does exist. So I will be supporting.
Dan?
Well, it's a tough one for me, because I do respect our sheriff and I respect Bob's opinion. I was the first podiatric surgeon on staff at Munson, and Dr. Martin and I walked into that luncheon together welcoming new doctors. He was brand new infectious disease. I was the brand new foot and ankle guy. So I'm the same vintage as he is. He's a lot smarter than me. For me, I can connect the dots. You can see how it's been enabling people. So you have to use the concept of triage, which is when things walk in the door, what's the most important thing? And yes, it might be enabling people, but it also protects a lot of innocent people. And my first calling is to be a doctor, so I'll be supporting this.
Okay. I originally came maybe not quite supporting this. As it happens, my son had a bike accident today on a rural road, and I had to go pick him up. And I got him home. He's okay. He dropped his headphones somewhere in the grass along that rural road, and we had to go back and look for his headphones on the way here. And I was amazed by, this isn't far from my house, and I was amazed by the liquor bottles and the beer cans in the ditch, and I saw 2 needles, 2 used syringes, hanging just sort of as we're walking, looking for his headphones. I don't want that. I don't want that. There's a lot of kids in that area walk around, and you know, somebody who doesn't know what that is picks it up. It shouldn't be out there. It absolutely should not be there. So, for that reason, I will also support this. So.
One more thing.
Yes, sir.
I think someone mentioned that it's reversible. If we find that in time this is an uptick in problems, we can take it back.
We can.
Yeah.
It's worth a try. Bob?
I have to comment because you're making it seem like as soon as we pass this, then there's not going to be a needle anywhere.
No, that's not it.
That's what you just said,
No,
basically.
I said
And
I said that's what changed my
still going to
mind.
be the case. There's still going to be needles everywhere.
There may be less.
There still will be.
But there might be less.
I'm
hoping.
find it hard to believe that personally. I mean, but
I hope it will
I know
work.
human nature, and I think they're more likely to discard them than so. And the easiest thing is just throw them what they are. So.
Sarah, roll call vote, please.
Johnson?
No.
Lathrop?
Yes.
Mayor?
Yes.
Wheelock?
Yes.
Gorfulet?
Yes.
Crawford?
Yes. Motion passes. Okay, thank you. Unfortunately, I actually have to go. And our vice chair isn't here. So what we need to do is pause for a minute. I have one thing to say, and then we're gonna have to vote on a temporary chair after I leave. And I'm probably Dan. But
Where are we at in the agenda?
we are right before IT and renewal of the Onyx agreement. We have already discussed.
Almost to 9C.
We have already discussed the administrator's contract because Mr. Cooney was here earlier.
So what number are we on?
We are on C1,
Under 9.
9C1.
9C1. So
Okay.
I can give you my agenda here.
Oh, thank
This
you.
is where
That'll
you would
help, yeah.
start.
Okay.
I
gotcha.
have one announcement or advice that I need from the board before I go. There's a gentleman that Ron had brought up several weeks ago about, he works for a capital company that is just insistent on getting an audience with someone regarding buying the pavilions. And this person, Nate, has talked to him, correct?
Yes.
Chris has as well. I believe Corey Hansen with the pavilions has spoken to him. Now he has moved on to board members of the DHHS board. All I want is your approval for me to call him and say, it's not for sale. If you could just say that's okay for me to put my hands in there and say, listen, I'm the chair of the board, this is not for sale, can you please? He is calling incessantly.
Didn't we already have this conversation?
We
Yes,
did.
we have.
I just want to make
And I
sure
think
it's
we-
okay for
Feeling like
everybody.
deja vu all over
To that
again.
effect,
is.
we've already had that, so yes.
Yes.
Yes, everybody's okay with me giving
Yes.
this gentleman a call and say, please, it's a done deal, we're not,
That's correct.
cease, please. Yes, sir.
See if he wants to build another one.
Well, it's a capital company that invests in,
Well, then if he's got the capital, let him build one.
whatever.
Well, Corey Hansen didn't talk to him.
He didn't. Oh, I
He
was under
didn't.
the impression they did. I'm
And,
sorry. I was
so-
incorrect.
That's okay.
I think
Why should he?
that anything that is FOIable, that he should have access to. Why should he have to FOIA it? Why can't?
If he wants
why-
the information, he can send a FOIA request and we can fulfill
my
it.
point is, I don't want to sell the pavilions, but my point is, the fact that we don't want to sell it doesn't make it a gag order.
No.
We should be able
It's
to
not a gag.
discuss
I
it.
guess I'm confused as
He
to.
can, no, it's not a gag order, but this gentleman, he is asking for audience with
Information.
different, he's not
He wants to
asking-
come before
He wants
the
to come
board,
before our board or the DHHS board, or he is not understanding that the pavilions is not for sale. If he would like to FOIA information and get information about the pavilions, that is available to him. That's not what he's doing.
I just
He's
think-
not going through the formal FOIA request process. He is incessantly calling
doesn't
board
take no
members.
for an answer is what you're
Exactly.
saying.
Yeah.
We could let Dan meet with him, but.
What?
Would you like to call?
I could talk to him, but I don't want to sell the pavilions, isn't that? It's just
Exactly.
I don't think it should be a gag order. That's
It's
all.
not a gag order.
It's not a gag
I'm not
order.
telling
This
anybody
board-
that they can't talk to him. They can absolutely talk to him.
And he
I
can
would
come
like
during
to call
public
him.
comment and say whatever he
can.
wants.
He can.
Good.
I mean, I just don't
He
think it should
can, and
be
I
an
will let
agenda
him know
item.
that, but he wants to be on an agenda to present, I want to buy, and it has not gone through the process, that is
Well,
not.
what is the process?
We haven't determined that it is a property we no longer need, according to our property disposal policy.
We have a disposal policy by which county
Yes,
property.
and
is
we've
supposed to
already
be
talked
sold.
about all of
We've
this.
already talked about this. We've repeatedly voted that the Grand Traverse Pavilions is not for sale.
Right.
And as far as I'm concerned, whether it's the administrator, the county board chairman, whether it's the director of the pavilions, everyone should tell the man a unified vote that the Grand Traverse Pavilions is not for sale, period.
Okay, so I just wanted to let you guys know that I will be calling him tomorrow and letting him know that. Okay,
Why
thank
don't you
you.
send him a letter?
Because then he'll keep calling until he gets the letter, and I don't even think that's gonna make it
Okay.
stop. So it just, yeah, it needs to.
Tell him we got a facility out in Kingsley that he might be able to turn into.
I'm gonna
one.
put him in any particular direction, but I.
Right, Nate? You
I-
can go with that.
At this point, I really am very sorry, but I have kid things that I have to take care of. And so I would move that in my absence, that Commissioner Lathrop be appointed temporary chair to finish out the meeting for me.
Support.
Moved by me, supported by Commissioner Wheelock. Any discussion?
Is that a wise move?
All those in favor say aye.
Aye.
Anybody at the end there opposed?
No.
Okay. So we're all
See
good?
ya.
See ya. Thank you.
You guys are going to regret this
There you
decision,
go.
yeah.
Thank you very much, and I'm
I
very
already
sorry.
do. No.
You're going to regret it. I'm really rusty. Okay, so
you.
we
It's all
are
yours.
at renewal of Onyx agreement.
Yep.
Okay, yeah, I get it.
Yep.
So who's next?
That would be me, Commissioner.
That'd be you?
Yes.
Okay.
Ming can't be here
Are
tonight.
you the
but
administrator?
He is.
July 1st.
Oh,
I
that's
was
right,
gonna say,
okay.
it says undersheriff, so I'm confused. Need a new sign.
I do. The Onyx agreement is an agreement that basically, it's a provider that we host our Google apps and our Vault system through, our Gmail, things like that. It's an annual agreement. The reason it's before you is the amount. It's almost $48,000. So we would like to have an annual agreement renewed with Onyx.
Did we have it bid?
Well, we could ask for a bid. We do not have a bid for this particular provider because it's Gmail.
Because it's what?
It's Gmail, Google, it's specific to Google.
I'm just curious if anybody else provides the service. I mean, for $48,000, we normally would bid.
The-
I mean, it depends if it's professional service.
There are other mail providers such as Outlook, providers such as that. That has not been something we've been entertaining historically, but we certainly can ask.
I just was curious.
Yeah.
Well, and
What
this-
other providers would charge.
Well, and this, I guess, if I'm not understanding right, this is just a networking company that's hosting this. So you could have other companies that could host that, I believe, on Google and stuff. So I don't know.
You know more than I do, Bob. I just, for $48,000, it's.
There probably aren't too many players in this game, though, is the other part of it. And I don't know how much money you're gonna spend to go through all this
Sure.
to save a couple
Sure.
thousand. so.
I'm not trying to be difficult. I just,
no.
I know that normally when we have a $48,000 contract, we get bids, so.
That is easy enough. We can go back and request
Well,
bids for the
when does
service
this-
provider.
How long is the this is being proposed as a renewal. When did we enter into the initial contract?
The term of the agreement is from July 8th to July 7th, so it'd be my assumption that the agreement is coming up for an expiration.
But is this the second year?
This
No,
says
it's
it 2011.
2011.
Why don't we enter into a multi-year contract is my question. I'm just.
It's a good I don't know the answer to that.
That's not that unusual either, though.
Okay.
A 3-year contract is usually, you know.
All of my web hosting contracts are all in 1 year.
Are they?
Oh, are
Okay.
they?
They're, you know, I use Outlook, I do use it, I don't necessarily think it's the best option out there. It's more cumbersome sometimes. You know, I guess I would make the motion to renew the Onyx agreement for Google Apps and Vault for a 1-year contract, and then probably before next July, we can look at the options to see if there's
I'd
something
support
else
that.
out there.
I'd support
You
that.
know, if our contract's up in July 7th, we need
We
to
don't have time.
renew that contract now. But I would ask that prior to July of 2019, we actually look at, are there in fact other options? We may simply find that there are not other options out there. And as Chris made the note, it is professional services. We don't have to bid that service.
Is there a second?
I did support that.
Okay. Any more discussion? All those in favor say aye.
Aye.
Opposed? Motion carries. Now we have Administrator. Corrective Action Plan for OPEB Retiree Health Plan.
So what you have before you is a memo completed by Mr. Bott and myself indicating a recommendation to you for a discussion tonight on how we can reach the 40% OPEB contribution very quickly. There's mechanisms here listed on the document in front of you, very easily can be attained yet this year, yet this summer, as soon as you make the vote. And we will submit it to the state of Michigan.
Go ahead.
Yeah, well, we're also waiting for the MERS report as to what our position is there as far as retirement. And we have the Blaine property proceeds to consider. So is it possible to put those two things back on the agenda at the same time, where we would be able to see what we need to bring the MERS up from that report? Take a look at the Blaine proceeds and
I thought we already committed the Blaine proceeds to the pension debt.
we talked about it, but we didn't commit it, actually.
we committed.
We committed
We
the
voted
Blaine
on that.
property proceeds for the pension debt.
Well, pension debt could include OPEB.
No,
No, it's
we
not.
already had that conversation.
Okay.
Separate issues.
There was conversation about that, Tom. but-
So are you saying that you have a way to pay it off right now to?
We can reach the 40%. There's existing funds at MERS right now for the purpose of OPEB. There's a 2018 payment that is already budgeted for. And what Mr. Bada has found is $249,000 in additional payment coming from the general fund will take us to that 40%.
Go ahead.
Okay, so I think this is the second meeting of June, right? And I thought by the second meeting of June, we were supposed to have numbers on what we had financially to work with and, you know, what our audit or we're supposed to have some more numbers so that we could make decisions on going forward with raises, with, you know, all kinds of things. So we're not there, obviously.
No, we're waiting, the big item is our MERS valuation.
Right.
And MERS is telling us that we'll have that by the end of June. We don't have our audit complete either at this point in time, but we know the numbers that we previously presented are not changing. The big piece of the puzzle that's missing is the valuation from MERS. Now, the way the Public Act in 2017 works, 202, it's based on where we were at as of 12/31/2017. We are underfunded in both our retiree health and the pension. That's not going to change. That's going to be reported to the state by the auditors, and it will also be reported by us because there's reporting requirements under that state law. We simply don't have information from MERS at this point in time to come back to you to say, are we 54% funded? Are we 57% funded? It's hard to give you a corrective action plan, but what we were desiring to do here was to tell you what we know at this point in time. I mean, this is the best we can do at this point in time.
Oh, okay, and I guess all I'm saying is that, and you found $249,000. I mean, where did you just find $249,000?
We did not find 240.
Well, that's what we were told.
Well,
Mr. Bott found $249,000.
We don't have our tax revenue budgeted at 100% of what we're going to receive. So there's additional tax revenue that could be budgeted to make the balance of the payment that would get us to 40% funded with our retiree health.
The 40% mark that we got to hit is based on December 31st, 2017. Is that correct?
Well, it's based on.
Or is it going to be based on the new MERS report? Because I mean, we're going to have to get to 40. We don't have a plan like we do with the pension, so we're going to have to get to 40.
The 40% is the number that's built in the act that was passed at the end of 2017. We do not have to do anything at this point in time. We just wanted to show you, here is something that you could consider when we are actually sending that corrective. We're not required to send anything into the state at this point in time, but we're trying to show you that, at least for the item that we know, because we did the valuation on the retiree health, here's a plan, here's a way to get there for that component of our two significant liabilities. This is the smallest one, but we simply don't have anything for MERS yet. We may not get that until June 29th.
We're going to have to align. We're going to have to get to 40% though to align with the state statute.
Correct.
So
what's unknown?
We do it at some point this year, but we're going to have to get to 40% of that. So,
Senator Wheelock.
Is there a date that we have to be to that 40%, Dean? It's not July 1 or something like that, correct?
Not to my knowledge. The first requirement is we report, and then at some point in time, if we don't voluntarily submit something, I'm sure somebody's going to be knocking on our door, hey, Grand Traverse County, what's your plan? We want to send something in relatively soon.
I guess what I would like to do, or I would, at least in my head, I think we ought to do, we know that we're already going to report as of December 31st, 2017, we were not 60% funded in our retirement, and we're not with 40% in our OPEBs. I guess I would rather sit on this decision for another week or so, hopefully, or a couple weeks, and have the MERS documentation, and then try to adopt something and say, okay, we need whatever, instead of needing 249, we need $500,000 or $1 million to address both getting MERS, or getting the retirement fund to 60% and the OPEB to 40%. We need this number of dollars. And then let's make a plan based on taking care of both of those at one time.
Tom's next.
Okay. Something that was said about 10 minutes ago is that we already decided what we were going to do with the proceeds from the Blair Township property that's known as the Blaine property, right? Okay. Who seconded the minutes? Was it me? Today? Seconded the minutes from the previous meeting? I think it was me, but maybe it wasn't. Yeah. Okay. On page 4, it says, Commissioners directed administration to come back at a future meeting with a recommendation on where to apply the proceeds from the Blair Township property. So that's what I remember. So we were still open to what we were going to do with the Blair proceeds, and I think we're all thinking the same thing, that it's going to go towards MERS, but that's what the minutes are.
We have solidly voted on numerous occasions that the proceeds for the sale of any county-owned property would go to the pension debt. I think that's, we've had that discussion on multiple occasions.
I think the issue for Tom is that he's considering OPEB as pension
part of
debt.
the pension debt?
Right. I think that's the.
I think there are two types of pension debt.
Right. I want to support what Sonny said, and that was going to be my comment. I don't want to piecemeal this. I feel like, I'm, again, not trying to be difficult, but I thought we were going to have the numbers at this meeting, and I'm sure you thought we were too. I mean, we all thought we were going to have numbers by June, and we don't. So I'd rather not do this piecemeal. I'd rather do it when we have all the numbers and know what we're looking at. Because there are, I know we have to do certain things for pension, but there's other things that we want to do too.
Okay.
Mr. Chairman, I would move that we table the corrective action plan for OPEB at this time.
Support.
Okay, any more discussion?
Chris, that's the easiest way, right, is to table it?
All right?
That's fine.
Any more discussion? All those in favor say aye.
Aye.
All opposed? Motion passes. Now we come to,
Animal control.
let's see, animal control. Cheryl?
The ad hoc committee has not met for a while. We did vote, I think, at our last meeting or meeting or two ago, to authorize administration to go forward with renovating the Keystone facility. I think that I would like to see us form an advisory committee for animal control like we have for Commission on Aging, like we have for veterans, for some of these other entities, so that we would have a citizen group that would be involved in keeping us apprised of what they're hearing about animal control or what concerns they have about animal control. I think it would also be helpful now that there's, we have a millage proposal that's pending, and it would build some momentum for that group to maybe help push that forward. But I asked Carol if we could form such a committee, and she said it would need a vote of this board. And she suggested that the ad hoc committee would be the committee that would be the people who would vet the people who would apply.
Okay, anybody? Go ahead.
I would support a motion to ask the ad hoc committee to come up with a plan for how they would assemble the advisory board, if there's people in certain backgrounds, or how many people, and how
The
often they would meet.
recommendation was
and-
for
yeah.
4 citizens and 1 commissioner.
Oh, okay.
Doctor?
Yeah, my concern, I mean, I think we need this, but I need to make sure that we limit some powers. If you read the emails that we've got, the reason they want to set this advisory is they want to completely run animal control. And that's just not going to be the case. I mean, right now, they're hot on this because of, whatever's going on with one of the employees. So if we do an advisory board, we need to make sure that their powers are in check, because there's a lot of emotion in that group with animals and animal control, and it's really.
My expectation would be, I think Chris put together the bylaws for the COA board. Is that right, Chris?
Yeah, I worked with Cindy Conlon on that.
Yeah. So I would expect that there'd be something similar, some guiding
Yeah,
principles.
as long as it stays advisory. I mean, like I said,
Yeah,
to me, it's got the makings of being a real mess at some point.
There
but-
is I'll be candid, there is a concern about the law enforcement function with the animal control officers, and that the advisory board not direct the ACOs when it comes to investigating dogs at large or dangerous animals and those type of things. That poses separation of powers issues when it comes to the prosecuting attorney and his role as chief law enforcement officer. So I guess my question is, what exactly is this board going to be advising on?
Sonny?
I am inclined to still keep the ad hoc committee to talk about how to make animal control better. I have a lot of concerns, like Chris is talking about, that, we have, animal control has 2 functions, a public health function and a law enforcement function. I don't believe that I want a citizens committee telling either one of those functions how to do their job. I have no problem with a citizens committee making recommendations of how to make animal control better, but I don't want them to control how we enforce the dog law and how we handle when somebody gets bitten wherever. There are very specific parts of the animal control law that have to do with law enforcement and public health. And we want the law enforcement part to be handled by the sheriff's department, and the public health department, the public health component to be done by the health department.
I think that this is putting the cart before the horse. We've only had the animal control department under the health department for what, 4 or 5 months? How long is it?
No, a couple of years.
2 years.
Oh,
No, you're talking about it back at full strength.
Yeah, back at full strength. I think we ought to let this little department go through the normal growth curve and give Wendy and our administrator and that department a chance to grow I think it's too many cooks in the kitchen. So we could do it at a later date. The millage hasn't even passed yet, so it's too much too soon. That's my feeling. That and I do agree that there's police powers and health powers. This is not like this is a little tiny budget, but not to compare it to Commission on Aging is, you know, they got a bunch of employees and a lot of money. There's nothing about this department that we can't handle with public input. So that's my point. Okay, go ahead.
Well, I guess my thought was that it would be a way to allow the public to engage in, perhaps in a way that would diffuse some of, you know, what you're referencing. You know, by having them be part of a conversation, like, you know, helping raise money to do things at the new animal control shelter, or, you know, being involved in educational, you know, one of the goals of animal control is to educate people about animal safety, or, you know, not keeping animals don't lock your animal in a car, or, you know, how to handle your pet in hot weather or whatever. You know, to give them more of a voice to educate people and be involved in that kind of process. Clearly, you know, an advisory committee would have no authority over policy. I mean, we don't have any, I don't think we have any citizen committees that form policy, do we, that I know of?
Sonny?
Well, I guess the prime example that comes to my head is Friends of the Easling Pool. They've educated people, they've raised money. We did not designate anyone to an an advisory board. We did not create an advisory board. Friends of the Easling Pool has raised basically $750,000 to renovate, you know, a county-owned facility with no authority per se given to them by us. And I really don't think we need the advisory board at this time.
Okay, so if animal control wants to do the same thing, you're gonna be supportive of that.
Mm-hmm.
Well, there you go. Problem solved.
Is there a motion or anything?
No, I don't think so.
Okay.
Call it Friends of Animal Control.
Whatever they wanna call it.
Whatever.
No. Another group could start.
Sure.
Wags and tails, I don't care.
All right, let's see. Animal control, okay, now we're up for second public comment.
Okay, I'm gonna make an exception, go over there.
Oh, okay. Gotta tell us who you are. Where you live.
My name is Tom Mayer, and I'm the District 2 County Commissioner. The city just received their ballots for the August primary on Monday. So these are sample ballots. Anybody can take a look at this. You can also contact the city clerk or your township clerk to find out about any questions you have having to do with the election. But you have to be registered 30 days before August 7th to be able to vote in this election. And if you would like an absentee ballot, you can get them right up to the very last day. There's no deadline on that. But they probably won't send out the absentee ballots until the last week of this month. The biggest change on this ballot is that there are now 3 parties that are participating in the primaries in the state of Michigan instead of just 2. I think it's the first for that. So the Libertarians are now considered a major political party. And the reason I stand over here is that I'm not in any of these groups. My political party is a color, green, and we're considered a minor third party, and we don't participate in the primaries in August in the state of Michigan. I don't know about any other state. But we just go directly to the November election. And I'm all registered, all my paperwork has been turned in with the county clerk, so I'm all straight and ready to go for November. But when you go to the ballot precinct and you vote, or you vote absentee, you're only going to be able to vote in one of these columns, and you're going to see 3 columns, and you've never seen 3 columns before. So I just am alerting you to that. And if you want to go to your clerk in your city or your township, you can get a sample and look for yourself. There's also 3 proposals on the back, too, and 2 of them this board approved. One is Grand Traverse Conservation District millage, and one is Grand Traverse County Animal Control Agency millage. All right? Thanks.
Thank you. Okay, anybody else for public comment? Okay, we'll close that. And then, any notices?
Just a quick commissioner report. Last night at the jail ad hoc committee, last month, I think I reported to you that we seen a expanded explanation of proposed benefits from Northern Lakes Community Mental Health. We got a written proposal from CCS, the current healthcare provider within the jail, and Dr. Conlon, who is the psychiatrist under contract in the jail. Those two proposals from CCS and Dr. Conlon were not fleshed out at all. They were strictly, here it is, $500,000 and no explanation of what it got. They were invited last night to come back and explain to us what we were going to get. Both of them declined to do that. However, we have had meetings with Northern Lakes Community Mental Health about possibly stepping up and taking over psychiatric services within the jail. As you know, they do some work in the jail, but the psychiatric services are currently on a contract with CCS, and they in turn contract with Dr. Conlon to provide the psychiatric and prescription of psychotropic drugs. Although even though she prescribes the psychotropic drugs, they have to be purchased through CCS under our contract with them. A little complicated around the edges, but I guess what I wanted to report to you is that we will be coming to you after our July meeting with some solid recommendations that include training of corrections staff, train the trainers of corrections staff, which will help us to do ongoing training moving forward. Those will be offered through Community Mental Health at no cost to us, which everybody likes free. And we will probably be bringing you a recommendation to expand a professional mental or a mental health professional in the jail, probably 40 hours a week. We are looking at some proposals that involve a peer group individual who will help people transition from within the jail out into the community, help them make the connections with mental health services that are available, addiction treatment services that are available, those kind of things. That also comes with a price tag. I'm not sure we're quite ready to make that recommendation yet. And we should, by next month's meeting, have a number from Community Mental Health. And I am sorry, right now I can't think of the doctor's name that is in charge at CMH for the psychiatric services. But he is actually touring the jail facility on Saturday with some of his staff, and we're going to see a proposal for them to give us enhanced psychiatric services in the jail. If that happens, we can see it from all different price tags, whether it's the same 20 hours of service that we are currently under contract for through CCS. The estimated cost to do that, at least in the preliminary estimate, is the same $75,000 that we're paying CCS. So we can amend our contract with CCS, take the psychiatric portion component out of their contract, and contract with Community Mental Health. Under any circumstances, I don't see, if we were to vote next month for this, I don't see any of this change to happen until at least the fourth quarter of this year. So it's probably going to have minimal effect on our 2018 budget, but I'm hoping to have it locked down so as that we can have solid recommendations for monies to provide enhanced mental health services in the jail in 2019.
Okay. Yes.
The Regional Forensic Pathology Committee met as well last night. I don't know what Dr. DeYoung shared. Did she share what happened last night?
Carol did.
Carol did?
Yeah.
Oh, okay, so you already heard.
Yeah.
We're not gonna come back and meet again till September, and we hope to come back to you hopefully by October with some recommendations. So
Are you looking at the Kingsley facility
We are
still?
not.
Okay, 'cause someone,
We-
one or
we
two of my
talked-
constituents had asked, and because I thought too that there seemed to be not really
We
well
talked
suited
about
for
it,
that.
but it's, we sure don't need that much space.
No, it's a lot of property.
It's a lot of, it's a lot of space, yeah.
And it's a long ways away.
Yeah.
Beg your pardon?
And it's a long ways away.
Well, and if you're gonna be regional, that's not as big of an issue, but I just don't think we need anywhere near that amount of space.
Well, people always say that facility because there's a building there, but you're limited on what you could use the building for.
Yeah,
You'd
it's
almost have to.
prison.
Okay, anybody else? All right. Now, we're gonna go into a closed session. Tell me how to do that. Do we make a motion to go in closed session?
Yeah, it'd be a motion to go into closed session to discuss pending litigation with outside counsel. I believe it's the case,
Right.
Wolf versus.
Motion to go into closed session for the purpose of discussing litigation in the case of K. Wolf versus Grand Traverse County with outside counsel.
I'll second. Go ahead.
Okay,
Okay.
second?
Go ahead.
Any discussion? All those in favor?
Roll
Wait.
call.
Oh, roll call, okay. Do we have to ask, or do we expect to make a decision?
I don't think so.
Okay, go ahead.
Lathrop,
Yep.
Mayor,
Yes.
Wheelock,
Yes.
Gorfulet,
You say no.
Johnson.
Yes.
You're a brat. Okay, we're going to go in closed session. Here we go.
We just got out of trial in Cadillac.
Yeah, you're gonna have to get a hold of her.
Yeah, I
I was not involved in the drafting of that.
Okay. Yes, I am.
mentally ill parent. I know, I understand. I know, it's like, I know. No, I know.
So it's performance-based. Okay, and 3,000 is correct? Okay. And then, has this been, I'm assuming this hasn't been signed yet, it sounds like they're gonna write up a formal.
Sounds like they.
So, I think it was Commissioner Lathrop, he said, excuse me if I'm wrong, but he said this would be the lowest paid